So welcome, everybody. Hopefully some more people will join in. Dr. Lopresto and I are going to tell you something about the resolutions process. I'm going to start and talk a little about the history of the process and the history of our organization, which I think a lot of people don't know. And it does have some bearing on why we want resolutions and what they do for both the profession and for our organization. And then Charles is going to give you some details about how that fits in the larger world of organized medicine, as well as what constitutes a high quality resolution that will be successfully processed. So I'm going to go right to the action and say that before 1998, there were two internal medicine organizations nationally, the American College of Physicians, which was founded in 1915, I believe, and the American Society of Internal Medicine, which actually split off from ACP in 1952. ASIM was more concerned about practice issues and reimbursement, and the American College of Physicians was more concerned with the academic aspects of medicine, quality of care, and medical research and progress. But the two organizations had two different structures. The ASIM was a 501c6 organization, a member organization, and it was built on what is called the federation model, where an assembly of delegates actually has the overall control of the policies and governance of the organization, even though there was a board and a president and an executive director. Whereas the ACP had this unique structure with a board of regents, which was advised by a board of governors, which reached down to the state level. And I pointed out that the AMA is a similar organization where the delegates really establish the policies, whereas the American College of Physicians is a little bit more like the House of Lords and the House of Commons before the Parliament Acts, when the House of Lords had the ability to basically override what the House of Commons wanted. The other thing about the American Society of Internal Medicine was that it depended on strong state level societies of internal medicine. In New York, we also had local chapters. And the resolutions process was the way that the members, through the local chapters and then to the NYACP Assembly of Delegates, would bring issues of concern. And it was a very robust process, as I'll show you in the next slide. They would direct policy that NYACP leadership would be obligated to follow, so that if they said that all the meetings will be conducted in Swedish, then they would have to conduct the meetings in Swedish. But obviously, there was a very robust detail of attention to the issues that were affecting the members of the organization. Some of those resolutions would be directed at the national policy, and they would go up to the Assembly of Delegates, and that would then direct ASIM executive leadership to take certain actions. There really wasn't a formal process for resolutions in the ACP at that time. There were floor discussions at the local meetings of the state level chapters, which generally were independent regions that only got together on occasion. But the ACP Board of Governors would be an advisory position. They could tell the Board of Regents they had a concern, but the Board of Regents could act any way it saw fit. And I'll give you an example of that later on. So the way that the formal process worked, and it's a parliamentary process, is that the resolutions would be submitted by members to a reference committee. The reference committee would have 4 or 5 members, and it would hear testimony on the day before the official meeting of the House of Delegates. The reference committee would then consider the resolutions, and the resolved part of the resolutions that Dr. Lopresto will tell you about could be modified, and the resolutions would then be presented in the form that the reference committee felt was most effective, or they could make a recommendation to reject the resolution. But that would go to the Assembly of Delegates. A report would be made. There would be floor debate, amendments, and all of the things that parliamentary debate require. And you needed somebody that really understood parliamentary procedure to be able to manage that. And then there would be a final vote to accept or reject. And this final vote became the policies and actions of the organization. Now, in 1998, when it became clear that internal medicine couldn't support two organizations anymore, and the two organizations were fundamentally beginning to deal with the same issues on a regular basis, some very wise people worked very hard to convince a lot of people who were kind of organizationally challenged to merge the two organizations. One of the main principals was Bernie Rossoff, who had been a president of NYACP and was at that time president of ASIM, and on the ACP side, Walt McDonald. And they did a fabulous job in breaking down barriers and merging the organizations. And for a time, the national organization was known as ACP-ASIM. And after several years, it became clear that that was clumsy and unnecessary, and everybody was comfortable calling it ACP. Because the ASIM functions had been integrated into the organization effectively and successfully. And it was clear that everything was working well. The ACP governance structure, however, was maintained as a condition of the merger, and the headquarters remained in Philadelphia, but the Washington headquarters of ASIM were transformed into the lobbying locale, and Bob Dougherty, who was with ASIM, was retained as our primary lobbyist. At that time, New York had 3 governors, and 2 additional regions were created. So we had a total of 5. And the local ASIM ACP chapter mergers were encouraged by a committee that had 7 representatives from each organization, and I was actually one of them. And we really were very happy to see that there was a lot of encouragement to get things going locally. At that time, the Board of Governors really had a very rudimentary process for resolutions and would send things up to the Board of Regents. The merger of the New York chapter took 2 years. It's a delightful story for those of us who were involved, but it would take a long time to tell you. But ultimately, it concluded in September 2000 with the new set of bylaws and the structure that you're familiar with a C3 and a C6 entity, the council and the board. Linda Lambert was retained in our Albany office, which we had moved up in 1997 from New York City to Albany before we even knew that it was going to be a merger. And Linda successfully ran our organization until she retired a couple of years ago. But what was important to us was to have a single functioning state chapter rather than 5 independent duchies of the governors. And the bylaws that were written substantially were about making sure that that happened and dealing with the finances and the politics in an effective way. One of the issues that was important for NYACP was to retain local districts for member involvement and for leadership development. We felt that was extremely important, and we wanted to carry that over. It helped a little bit that we had some money in reserve that were kind of belonged to the districts, and it made it easier to finance some district activities at that level because of that. And we also felt it was important to retain some form of resolutions process. But because it was no longer an assembly of delegates kind of governance, the formal process for resolutions had to change. Now, what are resolutions? What are they supposed to achieve? The first thing is, how else do we get member concerns in front of leadership? We certainly have a broad range of people involved already at the governance level in the council and board and on some committees. But there's a larger group of members that may have something to tell us or concerns that we need to hear about. Those resolutions will establish the policies of the organization and direct leadership to undertake certain activities, and retain some echo of bottom-up governance that I think is important in any membership organization. And it also, in making the resolutions happen, it shows that the organization can function in an orderly way and democratically within the rules of order. And if you've ever participated in a true parliamentary debate, where you have to bring motions to the floor and amendments, and you have to act on things in a certain order, and have various other strategies you can use to guide the wordsmithing of the resolution. It's really a lot of fun, and it's a very valuable way for an organization to function and for people to learn how to respect each other and speak to each other. So during those debates, we learn the capacities and capabilities of the debaters, which is important when we think about who's coming through the organization, starting at an early level of their involvement and maybe going on at some point to a leadership situation. We really can develop leaders that way and assess their qualities. And it also forces the organization and all its members to really have exactingly correct or agree language that they agree on, so people mean what they say and say what they mean. And once the resolutions are passed, they become the policies of the organization or the actions of the organization that all members should be supporting. For the national ACP, what happens in New York goes up to the governors, and at the national level, the resolutions process has given the governors a bit stronger influence with the Board of Regents, because the process is formal, so the Board of Regents has a tougher time blowing it off. And I'll give you an example of something that happened in the past that illustrates that. The resolutions express the concerns of the membership. They directly impact our policies and our activities. They bring new issues in front of leadership and direct the organization policies and the executive leadership's actions. And they can petition the national ACP to take action on national concerns. You know, even national concerns have to start somewhere with somebody saying, hey, here's an issue. We don't want the Board of Regents to decide what the organization is going to pay attention to. The resolutions, there's more information on the New York ACP website. I took the liberty of shrinking down this long link to something you can remember on the is.gd website, which is a site where you can shrink down your long URLs into small ones. And so if you go is.gd/res New York ACP, you come to the page that has this information. It has an online resolution form to help you out. It tells you a little bit about the process because there are multiple routes to bringing it into the organization now. So the one thing I wanted to tell you before, because I took the slide out, Charles, that you're going to be speaking about how it sits with the national organization. But when the two organizations merged, one of the bones of contention was that the American Society of Internal Medicine had a political action committee, which it felt was important to engage legislators and bring medical issues in front of them. Obviously, there's a concern about the fact that to do that, you're basically bringing them a campaign contribution. And the national ACP did not have a political action committee. When the organization merged, a lot of the former ASIM members felt that we should have an ACP PAC and continue that. And the Board of Governors debated it and voted in a ratio of 3-to-1 to have a political action committee. And all that could do, of course, is send it up to the Board of Regents. The Board of Regents decided to send it to two committees of the Board of Regents. One was the Ethics Committee and the other was the Health and Public Policy Committee. The Health and Public Policy Committee was wise enough to believe that it is something that you need in the modern world of advocacy. But the Ethics Committee felt that it was unethical because it involved money. And based on that, the Board of Regents, which was a lot of carryovers from the prior organization, rejected it. And it took about 3 years for us to finally convince them that it was not unethical. It was good for the organization. It was voluntary. And it would do good things for our ability to advocate as the combined ACP and ASIM really took on a strong physician representation, action, and attitude. And I have to say, I was on the initial PAC board, the founding board, and it was an important organization at the time. Obviously, money is an issue for any advocacy environment, and we may not like that, but the fact is that it's something that's there, but to get it done shows a little bit about the value of a process where you have resolutions coming from members that direct the organization. And so there was more of that coming up in the 3 years that we debated it until we finally got it passed. So I think that I'll stop now and just say that there's a lot to the resolutions process, to the extent that we can have it be something that people participate in on a regular basis at ACP. I know Loretta wants to do that, and there are environments to do it. It's a little bit spread out because we have no longer a delegate structure, but I think it's something that we all feel is really important. So I'll stop there and stop my share.
Thank you so much, Dr. Faltz, for all of that wonderful history of the two organizations and the structure of all these things. I believe I'm sharing my screen now.
Yes.
If folks can see. Let me try to move this over. Just one moment. I have two monitors open. There we go. It's centered for me now. But yes, thank you so much again, Dr. Faltz. I think it's really important to understand the history of the organizations and the structure of how the process happens in organizations if we want to affect change. Without that knowledge, it's really difficult to be an active participant. So with that being said, I'll introduce myself for those who don't know. I'm Charles Lopresto. I'm a hospitalist at New York Presbyterian Queens. I'm the vice chair of the Resolutions Committee or Task Force, along with Dr. Faltz as our chair. I serve as a newly elected counselor for the Organized Medical Staff Section for the Medical Society State of New York, also vice chair for the Young Physician Section for MISNY, and president-elect and legislative committee chair for my local county medical society for Queens. So let me go to the next slide. So I'm going to start with a statement that I believe in. All physicians should produce research and be advocates. I think we're all probably on board with the first part of that statement. We're all trained in this traditional academic environment. Okay, we learn how to do research as even a college student or a medical student, and for sure as we go through residency and fellowship. But what about that we should all be advocates? Should we? I mean, what do we think about that in terms of how we're taught and how we become physicians? So I think we know that we're trained to do research, right? Whether it's the AOA or the ACGME curriculum, there's elements for the medical school curriculums that focus on the fact that we should understand how to do research and how to interpret research by the time we graduate medical school. That's pretty well understood. But do we focus so much on how to train each other or be trained as advocates? The answer is we actually do. Under the ACGME guidelines for system-based practice for residency curriculum, it says residents are expected to advocate for quality patient care and optimal patient care systems. It's a nice line to have included in the curriculum, but do we actually get any training doing this? In my experience, not much. This is sort of a hidden curriculum, as people like to say, but I found through my medical school and residency training, I've had some mentors outside of the hospital, outside of my formal program that have focused on these types of things. And I'm happy to share some of the things I've learned with you folks tonight. So I go back to this concept then, if we're expected in our curriculum that we just saw to be researchers, we take that pretty seriously. We're also expected to be advocates. What happens with the second part that we're expected to do? Who are the people who pick up advocacy in our organizations or as physicians in general? I pose to you folks as the audience, if not you, then who? If we are identifying problems in our workrooms or with our colleagues or at our meetings and saying, hey, it's terrible. I got this prior authorization. I've been on the phone for 2 hours, or, I can't do this. I can't do that. What absolves you from being that person to take it further and try to make that change in our system? I think it's all of our professional responsibility actually to go that next step and live up to our training, supposedly, to be the advocate for our patients, at least as defined in the curriculum. Here's another problem. Here's a member of Congress who understands science. Okay, it's not that great. I have to update this slide. It's probably a couple of years old, but it's probably around the same. There's not too many physicians or people who hold doctorate degrees in the United States Congress. So when it comes to us trying to define our problems or trying to say, hey, we did this research, we know these guidelines, we should be practicing medicine this way, it's not these people in Congress who are going to be picking up JAMA or our ACP journals and trying to interpret the data and craft policy to make it easier for us. No, it's our responsibility to try to address this problem. The solution is us and organized medicine. This is our mechanism, how to be advocates. This slide seems a little bit complicated. I'm going to come back to it, but I just want to put this framework in everybody's mind that there's different levels that we can be involved at organized medicine and how to try to address our advocacy issues. So I'll first ask a question, and we can make this interactive if people want to chime in. If people just want to meditate on this question, that's fine too. What makes you passionate about medicine? Dr. Faltz, I might ask you. What stirs your pot? What makes you say, I want to wake up in the morning and I'm passionate about medicine?
I always like the challenge of serving the patient and challenge of being right and being thorough. And I think exercising the science.
Beautiful. Anybody else want to chime in? Well, if you don't, that's fine. Or I see Dr. King, I see you unmute yourself for a moment.
Yep, I can chime in. I was just going to say, I think being able to, I think it's the relationship I have with my patients and knowing that I am able to provide the best medicine I possibly can to them. And that includes, what you were saying about doing research and about, I think the advocacy, making sure that we can continue to preserve that relationship and preserve the ability to provide really high quality care.
Great. So for everybody else, keep an idea kernel in your mind. What are you passionate about? What makes you, wake up every morning and say, hey, I, enjoy being a physician, and this is why I got into this. Now I want you to shift that focus. What's part of the system or law surrounding medicine that has prevented you from practicing medicine in a way that you're passionate about? So I don't know, Dr. King, if I could pick your brain, what's something that you experienced that you say, oh man, well, I can't have that relationship with the patient that I wanted, that I'm so passionate about. Or Dr. Faltz, maybe you have a note to chime in.
Well, I come from an earlier era, so the changes are massive. I had to pick one thing. I think that it's the change in the reimbursement system that have really put non-physicians kind of in charge of value judgments about care.
Right. So I totally agree. And we all, experience this problem all the time. Why is, an orthopedic surgeon who is swinging a hammer valued at this amount, and my cognitive ability as running a hospitalist service for 12 hours a day valued at this other amount? And why is the primary care physician expected to have a 15-minute visit, and all these valuations and this whole reimbursement process? Very frustrating, right? A lot of details there, a lot of ways that we can think about that as a problem. So I want everyone to hold on to that thing that they might think is, hey, this is a problem. I can't do medicine because of this barrier in my way, right? So, okay, we found our problem. Great. What do we do with it other than complain to our colleagues that, hey, this sucks, right? Excuse my language. We found it. What we do is we have to define our problem a little bit better in terms of if we want to do advocacy the right way. So I encourage everybody to think, when they define one of these problems, what is their barrier? Is this something that's at the county level? Is this something that's at a state level? It affects all patients in New York State. Is it something that's at the federal level? That, we were talking about reimbursement as a possible barrier. That's mostly a federal issue. Or is it something that, I don't know, I'm having trouble with getting recredentialed in my hospital, or maybe there's some other outside organization, an educational organization that's related to my problem of what I'm having professionally, and I want some change to happen. So we have to think about what are the overseeing bodies of what the level of our problem is first before we are able to focus on our change. So that brings us back to this slide. This is what I've developed, what I'm calling a medical organization policy roadmap. Right, so I'm using my home county as an example here. We start at the bottom. That's the seal for the Medical Society of County of Queens. And what can I do if I have a problem that I think, hey, this affects patients here in Queens, and I want to do something about it? Well, I can write a resolution, bring it to my Medical Society County Queens chapter meeting, or my Bronx, Queens, Manhattan, I think, chapter of New York ACP meeting, and say, hey, this is an issue I'm having. What can we do about it? And there's two options, really. If it's something that just affects the local, patient population in Queens, we can go to Queensborough Hall, which is this building here, and say, hey, we passed policy within our society, chapter meeting, and we want to advocate to do something to change. Let's say it's something more national level. We could craft that resolution at the county level and have it bumped up to the Medical Society of the State of New York. Or likewise, have it bumped up to New York ACP, or here's another group that's a state group, the New York State Osteopathic Medical Society, right? And all these organizations can sort of do the same thing. They can either advocate at the state level, this is our state capital at Albany, and go talk to legislators to make some changes once we pass some resolution policy here, if that's what it prescribes, or they could take the directive to bump up another resolution or internal policy changes to national organizations, right? So we have our AMA, we have our ACP, we have the American Osteopathic Association, and other national or specialty societies, and then they repeat the same process. If it's something that they can advocate for, they can go to Washington, D.C. and talk to senators and Congress people about things, or they could influence other organizations, like I was talking about before, educational organizations, just as an example, AAMC, ACGME, ABIM. Maybe there's things that a member wants changed with how these organizations function, and there would be another resolution or policy memo to those organizations. So I hope this helps sort of separate in people's minds, okay, I have a problem, what level is it at, and what are the organizations that I'm going to go bring this to? So how do these organizations affect change? So Dr. Faltz was talking a little bit about it in terms of the history of ASIM and ACP, but more generally, I like to just keep track of that, each organization has a constitution and bylaws. Some of us think this is a little bit boring sometimes. They go, oh, well, that's for the leadership to discuss. But I encourage everybody, if you really want to be an advocate and understand how to make change, you should understand a bit about the constitution and bylaws of the organization. That's how the organization functions. And if the organization is not doing something on the advocacy front that you think it should be doing, it might be in the constitution and bylaws that you might want to request a change. So keep an eye on that. Other things that Dr. Faltz was mentioning as well, committees and task force. This is where a large majority of the work gets done and policies get recommended for the organizations to act on. So it's very, very important that not only if you want to submit a resolution, that's one avenue to try to direct a committee to make some change, but also join a committee. Once you're in these organizations, try to get on some of these committees, and you could be one of those voices in the rooms that's you turning the wheels and the gears to make these organizations actually move forward with policy recommendations. There's direct advocacy and awareness campaigns. There's social media campaigns that we see these days. It used to be mailers in the past. And then there's also direct lobbying of the legislature through sometimes affiliate organizations, as Dr. Faltz was mentioning, the political action committees. And lastly, there's actionable policies of organizations, meaning how the advocacy toward other organization ideas, like I was talking about before. If say, ACP has now the policy to advise ABIM on topic X, then that's an actionable policy. They have to execute that. And that's what they'll do for that year. So the question, who decides what's advocated for? It's very nice that we understand what these organizations can do now, but do we sit back and say, oh, well, I'm just a member and, I'll let the board of governors or I'll let the executives take care of it? No, it's you. You get to help determine what is the focus of these organizations. Remember, you're the person who found that problem, right? You're the person who said, this is the thing that's impacting me, that's preventing me from practicing medicine the way I want. So you can affect change. I return to Mahatma Gandhi, who said, be the change you wish to see in the world. It's up to us to make the idea, our idea, that thing that was bothering us, the advocacy priority of our organization, by introducing it into the business of the organization via some mechanism, whether it's resolution, sitting on a committee, being in leadership. But it's always up to us. And unless we actually take that step, bridge that gap to bring the issue forward, we won't be that change that we want to see in the world. So how do we do this? Through a resolution. So what is a resolution? This is my graphic from Schoolhouse Rock days. If those remember, we've learned about bills from when we were in elementary school, but maybe some of us remember, some of us don't. So a reminder, what is a resolution? Is sort of the idea of a bill for us within these medical organizations, right? It's a written request to an organization's House of Delegates or council or board to take an action. If I have to define a resolution in one sentence, I always define it this way. It's to identify a specific problem and offer a specific solution. I think this is important to remember because a lot of times people have an idea and they say, oh, well, I need to write a resolution. I need to get this taken care of. And in the writing process, their idea is sort of lost along the way. They're not really being specific, and they come up with something on the page that doesn't actually do what they wanted it to do. So I think as we learn more about this resolution process, it's always important to keep that true north in mind. Identify a specific problem and offer a specific solution. If you keep that in mind when you're writing a resolution, I think you'll be more successful. And understand this is how our voice is heard within our organization and how we can make a change. So here's an example. This is a resolution that I helped write actually, that went from my county medical society in Queens. It was submitted to the Medical Society State of New York House of Delegates. And then eventually, based on what it called for that the Medical Society State of New York to do, it became part of New York State law eventually. So what was this resolution? We'll break it down in a moment, but just in summary, I want to tell you a brief story about where this idea came from. As I said, I'm from Queens. If anybody had followed local news, or I think it might have made state level news at some point, back in, I think it might have been 2019, St. John's Episcopal Hospital, small hospital in the Rockaway Peninsula, southern Queens, they were having an issue where some external auditors were coming in and evaluating their hospital and trying to talk to leadership to say, hey, we think that you should close, or we should convert to this other type of facility and you'll make more money. And these types of conversations sort of came out of nowhere. Private equity is a big problem these days in our medical system. So I heard about this as a member of the Medical Society of County of Queens, and I thought, well, this is terrible. This is, St. John's Hospital. It's a safety net hospital. Anybody who knows the sort of layout of where that hospital is in the borough of Queens, if you close that hospital, there's a whole bunch of patients in that neck of the woods that are not going to be served. There's going to be more strokes, more heart attacks, more things that, go unseen, and care is going to be affected. So I said, this is ridiculous. Just because of private equity interests, we can't, let our hospitals just go close whenever they want. So we wrote a resolution that sort of asked for the state to say, hey, if you're interested in closing a hospital, you have to have a meeting with those stakeholders of community members, leadership of the hospital, any other vested partners, and have a real conversation about what are the economic reasons why we're closing this hospital and how it's going to affect the community. So I took that idea, wrote it up as a resolution, brought it to my local county. It went to MISNY, it passed MISNY, and eventually made it up to the House, to the New York State Senate. And we live in a different world because of that now. So I just want to use this as an example to let people know is this possible for you actually to create change? It's not just a bunch of, parliamentary procedures and whereases and resolved and second order amendments and all the possibly boring stuff. This is the physical mechanism to make change. So breaking it down a little bit more, right? So we remember we have our problem, right? We know which organization now we're going to make the change. We went through our grid before of, is it a county thing? Is it a state thing? Is it a national thing? So what do we do? How do we write this resolution? So here's how I would recommend that you start writing a resolution. You actually start with the resolved clauses. This is a little counterintuitive, but it's a little bit like research, right? When we write research, we don't write our conclusions first because we need to collect our data, but we need to start with a strong hypothesis or a strong research question. If that's not established, then forget it. Our whole study might be flawed, right? So I recommend people start with the resolve clauses. The resolve clauses are the part that is the quote unquote offer a specific solution in that sentence I said before, identify a specific problem and offer a specific solution. So how do we go about writing these resolve clauses? And I just want to put this example up from what was the example resolution before. I'll read a couple of them just to see, so you guys get the flavor of what a resolve clause does. A resolve clause tries to ask for something specifically, right? So the first resolve here says resolve that the Medical Society of the State of New York and the medical community stand with urban, suburban, and rural safety net hospitals and their communities, and against those who would take advantage of vulnerable populations that do not have the financial resources or political clout to spend on staying open against the monolithic health systems that are profitable and powerful. And be it further. So that's one thought, right? That's one resolve that said, hey, MISNY is going to take this policy and stand with these communities and hospitals, right? The next thought, MISNY in collaboration with other stakeholders will seek legislation or regulation to prevent any further hospital closures in New York State until stakeholders, including community-based groups and physicians in the neighborhood served by each hospital, have been able to have real input in closures and decision-making process. And it goes on. So the idea, again, each resolve clause is a specific ask. The first one that says this is going to be MISNY internal policy, that we stand with these groups in this way. The second resolve asks to seek legislation and regulation, right? So each resolve clause has to have that specific solution that we're asking for. Because at the end of the day, when these policy decisions get argued before a House of Delegates or a Board of Governors or at a meeting in that parliamentary process, we can have all the greatest reasoning in the world. If we don't have on the page what we actually want passed as policy in these resolve clause, it's not going to matter. So again, each one of these offers a specific solution that we're looking for. Last thing I wanted to point out on this slide is you have to research existing policies from your organization. This is something I see as a problem all the time, where somebody comes up with a great idea. They say, hey, we should be focusing on this. I want to change the way MISNY or the AMA or ACP feels about this issue. And it turns out that somebody actually already had that idea and the organization already has policy on it, or perhaps very, very similar policy. So before you actually start writing your resolve clause, it's always a good idea to look at the existing policies of the organizations, right? So this is a screenshot of the AMA's website. They have an AMA policy finder, it's called, on their website, where you can go search by keywords, you can filter by year, you can filter by what meeting it was passed at, et cetera. I know ACP has something similar, and I think we had some conversations between Dr. Faltz and Loretta and myself that we're going to try to update our website to include a similar type of mechanism to review our past policies as we encourage everyone to craft new resolutions. So, okay, we have our resolve clauses down. They're firm. We know what we're asking for. Now we come to these whereas clauses. So what is a whereas clause? It's where we provide evidence for the action that we're asking for, right? This is sort of the introduction to our research paper. This is the methods, so to speak, in a way, where we're giving references and saying, this is how we're defining this problem, right? Again, in my sentence, this is identifying the specific problem. And it's encouraged to use references when appropriate. I, as somebody who sat on reference committees and sat on, policies, organizations that have helped interpret these policy suggestions and resolutions, I'm always more impressed when I see an author include relative references to give me something to understand, okay, this is the context, this is why we're asking for this change. Whereas when somebody might just, submit based on their own ideas or their own opinions of why something is a problem. Maybe that's what they think, but maybe that's not really the best way to define the problem, or maybe not everybody agrees with defining the problem that way. So I'll save you folks the exercise of reading through these whereases, but this is, just sort of, again, an example of what it might look like. Each separate thought about, defining different elements of the problem. And you start the sentence with whereas. Sounds confusing, but it's just start the sentence with whereas, and you'll be on your way in no time. Let's see, trying to get to my next slide. So the finishing touches. After you have your resolved and your whereas, what else do you need to submit it? You need a title. Sometimes people spend too much time thinking about a catchy title, so that when people, who are at the meeting, reviewing the resolutions beforehand, they'll see a title that's inflammatory or, has an interesting topic, and they'll say, oh, well, people are more likely to read that. Maybe that's true, maybe that's not. I prefer to keep it focused on what you're actually asking for change. As I discussed before, having some references, it's not necessary, but I think it's helpful to make your case. Make sure that you review, as with anything that we submit, whether it's research or these types of, resolutions, check the website for the organization you're going to be submitting to. They might have some formatting guidelines, and I think we have some resources like that on our website. And sometimes you can also include an explanatory statement. If everything that you wrote in your whereases and resolved maybe requires a little bit more history or some context, you can include what's called an explanatory statement that's more of like just a narrative explanation. And lastly, also importantly, a fiscal note. Some of these asks that we ask in this resolution process, they can be a great idea, but if they're not feasible, or they cost, thousands of dollars or hundreds of thousands of dollars sometimes for an organization to carry out a certain advocacy goal, I think it might be useful for the decision makers when they're voting on that policy to know that, hey, this is a pretty heavy ask that we're asking for. And maybe there's some other ways that we could address some similar issues, but with a less heavy fiscal note, depending on the budget of the organization and the priorities, of course. So I hope that that was helpful in terms of giving you folks a roadmap to say, this is how these medical organizations are organized. This is how I can introduce a resolution at a specific level and either go at the county level, state level, national level, how the organizations interact, and a little bit more about the different components of a resolution and how we can use them to our advantage. So that's going to be it from me. I have my email up here if anybody wants to do any collaborations, writing resolutions, perhaps. I'm always open to that, or any other feedback. And Loretta, I think we wanted to save some time for if anybody had questions, right? I think now would be the best time for that.
Yes, that would be great to open it up to any questions from the attendees this evening. We can make it a little interactive if you'd like. So if you want to take yourselves and put yourselves back on video so that we can see you and respond to your questions, that would be great.
I see one message in the chat here. Michael says, thanks for taking the time to explain the organizational changes that were instituted to prepare physicians to do valid research and to advocate for patients. Right. So I think it's important to contextualize all of this, right? It's that we do so much work as physicians, people focus on academia sometimes to say, hey, I'm going to publish and I'm going to share my results with the world and I'm going to, make a difference. And we sometimes lose sight that, great, we're publishing, we're getting our information out there, but what's the next step? What's the implementation of what we're calling for, right? And that's what this second part of organized medicine is about, the resolution process, the advocacy part. So happy to help contextualize that for you, Michael.
I think there's a major difference now than there was in the distant past when medical organizations were there to protect physicians. And it's clear now that medical organizations can only exist if they support patients. If the outcome is patient care of a high quality that's affordable. And to the extent that back in the day, when many of these organizations got started, there wasn't a presence in between the patient and the doctor of any kind. Insurance companies paid indemnity. Patients may be paid cash, or they didn't pay anything, or they didn't get care, and nobody cared about that. And it's a very different world now. As a result, it's much more complicated. The organizations have a lot more to do. They have a lot of contacts that they have to make, both in terms of public policy and in terms of dealing with other kinds of organizations, whether they're drug companies or payers or associations of payers or government at different levels. So I think that there's a ton of stuff that needs to be addressed, and the members, coming from their own experiences, you can't address it all at once, and there's no one resolution like let's overthrow 18% of the American GDP and take it over. Isn't going to happen. So it starts with the little things that need to be changed. For example, what you did in Rockaway. I believe if St. John's Episcopal closed, there wouldn't be any hospitals in Rockaway, right? Because Peninsula General closed many years ago, and imagine, especially a community that is not only has issues of service delivery and income and the amount of money that they have, but it's a long, skinny peninsula that takes a lot of time to get from one end to the other. And if there isn't some healthcare in the middle, it's going to be a serious problem. And the state organization wouldn't know about that particularly unless somebody locally brought it up. So a lot of these issues, and then of course it bleeds onto issues of who's controlling the money. And you mentioned private equity. That's a big problem now for healthcare, where these organizations are not responsive to almost anybody except themselves. If we want to practice medicine, the first thing we need to do is be in an environment where we can be effective on behalf of our patients. It's always been the mantra of NYACP. We serve patients first. I think all of us would agree that that's the core. And so the problems that one has in environment A versus environment B need to be brought out so that the organization can assist them. There isn't even going to be one solution for all those things, even at the micro level.
Right.
So,
I totally agree with that. And if people want to raise their hands or put things in the chat or just chime in, feel free to, because Dr. Faltz and I will chit chat all night to fill space. Donna, I see you unmuted yourself. Did you want
Yeah.
to?
Can you comment a little bit more on how these resolutions actually impact the actions of the organization? I thought your comment recent about how one of the first things you should do is check to see if your organization already has that resolution was interesting, because it sort of implies that you have all these resolutions and nobody really knows anything about them or does anything about them, and a lot of time is spent debating them. So I think that piece of it is still a little bit opaque. How the organization takes these resolutions and actually puts them into action. And as a second comment, because some of them seem so vague or sort of global in terms of the action that would have to be taken, that it seems like no organization could possibly actually put them into practice, and they seem more aspirational than anything. And maybe there's a role for making aspirational comments, but if you can contextualize that a little bit, I would appreciate it.
Sure, Donna. And that's a great comment and observation. I think that this is probably the people who understand how these organizations really get to use their power are the people who are asking questions like that. I think language matters, and what we actually put on the page in those resolve clauses and what resolve clauses have been passed in the past that have become the policy of the organization, what the language is really going to dictate, what happens with that resolution, right? So I showed you an example of my resolution before, that we had some language that we partner with sometimes it's vague, but it's intentionally vague, but it's still specific, if that makes sense. So I think, one of our resolve clauses was something like partner with relevant parties to seek legislation and or regulation to do X, Y, and Z, right? So that is a specific action, even though it's vague. It's that we want this to be changed legislatively. We may not have a law in mind that we want changed specifically, but we do know that we want a legislative fix for this at the New York State level, right? So if we want something changed legislatively, it should be written that way in the resolve clause. And likewise, when we look back at policy, we should look, what is the policy that we have in our books? Is it just to say that ACP supports high valued care, or New York ACP supports a single payer healthcare system, right? It's one thing for an organization to take a stance as their policy and say, I support this. That's one thing. It's another thing if the organization has policy on the books that says, I support this and I'm subject to seek legislation or regulation to change it or to make it a reality, right? So I think when we look at what policy is already on the books, we can use that as a filter to say, okay, I see that we're supporting concept X, Y, and Z. Maybe the policy on our books isn't strong enough. Maybe the resolution I want to write is to amend the current policy that we have to make it stronger, to change a few words from support to advocate for, or something like that. And oftentimes you'll see what some authors of resolutions do is they'll break down those resolve clauses into those specific items so that they can leave it up to the House to decide, hey, the first item might be that we support a certain concept. The second item might be that we take advocacy steps toward making this a reality. And maybe the House might say, yeah, sure, well, we're comfortable supporting it, but not taking that second step. And they can accept the first resolve clause and not the second. Sometimes that happens. But I think it's about the language and what that language means in terms of driving the organization forward. Dr. Faltz, did you have some comments?
Yeah, we have a policy compendium that has all the policies that were passed by the precursor organizations, the New York ACP and NYACP, and it lists basically all the resolves. And then periodically, I think every 10 years, we're supposed to review them. Now, obviously, a lot of stuff from the old days just isn't relevant anymore. Medicine environment has changed so much that they just don't apply. So we eliminate those. I don't remember the last time, Loretta, when we looked at it. I looked at it a few years ago, and it's probably time again. And that should be, we talked about putting it on the website because it really needs to be there so people can refer to it. And it's just funny because while you were talking, I went into my file here and I found a resolution from 2015 that kind of illustrates how specific a resolution can be. And this one was about observation. And remember that you're supposed to bill a different CPT code for an admission, history and physical, and for a patient who is, you can't use the word admitted, right? Who's being put on observation, many of whom end up being admitted anyway. And presumably, if you have a patient who's an inpatient, but you bill an observation code, they could deny it and vice versa. So this has some whereases, and then it has one resolve that the New York chapter of the American College of Physicians ask the National American College of Physicians to petition the Center for Medicare and Medicaid Services to adopt a single code for admission and ongoing care by physicians that is payable regardless of whether the patient is in an observation or inpatient status. So a specific ask like that, is very directed. In my folder that I have on my computer, I have some other resolutions from about that time, some of which are just stating that it's important for the national organization to espouse a particular point of view, even if it's not seeking necessarily an action, but it would publicize that is in favor or against some change. So there's a great range, and as you mentioned, it's because you need to direct what the organization is going to do or say. These organizations have a public face. The ACP has a president who's often on media, and all of that stuff is available to members to decide whether they support it by if they don't, to try to change it. But one thing I will say is it's important in these organizations that once the decisions are made and resolutions are passed and the organization has policy, that everybody support it. And you know, one of the things I learned about advocacy back in the day when I started in the late 80s was you don't always win in advocacy. The political process, if it was rational, which it is less so today, I think we would all agree that it used to be. But the idea of politics is that you win some and you lose some. But everybody has to rally around the organization so the organization remains strong. And it does that by sharing concerns and by debating how the organization is going to function and what it's going to do. And sometimes the thing that you think is important, you convince other people that it is, and then the organization does it. Sometimes they convince you that it's not so important, and you say, you know what, we won't do it this time. But I think it's very healthy it's the only way to go forward in a world that is so complex now that we have a small voice, and our voice has to be finely tuned and sharp in that sense.
Excellent comments, Dr. Faltz, excellent information. In addition to that, I want to agree with what Dr. Kellen King said in the chat. It was a great webinar. Thank you to both Dr. Faltz and to Dr. Lopresto. Obviously, you both have expertise in this area. That is why you're chair and vice chair of the Resolutions Committee. We would definitely like to see more resolutions come out of the committees or task forces so that the Resolutions Committee can do their job and also help address any of the issues that come up from the members of our great organization. So before I conclude, because it's 8:02, just want to give Dr. Lopresto an opportunity to make some final comments.
Thank you, Loretta. My final comments are, I'll just re-emphasize some of my main points. A resolution is something that defines a specific problem and offers a specific specific solution, pardon me, and also be the change you want to be in the world, in the words of Mahatma Gandhi. That's what this is all about. If we don't stand up and be that change through this process or otherwise, then nothing's going to change. So thank you for having me, and happy to share the knowledge and expertise that I've accumulated. Thank you.
We appreciate it. Thank you. Dr. Faltz, final comment.
Yeah, my final comment is how I got started in what was then NYACP, and that was back when I first went full-time at what was then Booth Memorial, which is the hospital that Charles practices at now, New York Presbyterian Queens. And I was walking down the hall, and one of the very senior community internists stopped me in the hallway, and he says, listen, I want you to go next Tuesday to a meeting of the Queen's Society of Internal Medicine. And I said, well, what's that? And what am I going to do? He says, listen, it's organized medicine. It's heard about NYACP, but you never thought about being active. But I will tell you, this is what he said. The guy's name was Harvey Schildkraut. He said, when you get involved in organized medicine, you will meet the best people in medicine. And, I thought, gee, the best people in medicine are, the professors at the medical schools and whatever, and they're great people. But it turned out that the best people in medicine were at NYACP and ASIM and ACP, and they remain there today. So I think we want to encourage people who are practicing not to be feel that they're isolated, and that, in fact, by being involved in the organization. And the main way to do it at the level of entry is to get involved in writing and then speaking about resolutions at meetings. They will meet the best people in medicine, and it will enhance their career and their lives immeasurably, as it has mine. That's what I can say.
Wonderful. And we encourage everyone on this meeting tonight to get more involved in the chapter. We would welcome you. We'd love to have your participation more actively, and hope to see you at the next meeting. So thanks everyone for being here. To our speakers, thanks again. And I hope everybody has a nice rest of the evening. Take Take
Thank
care.
you.
now.
So long,
Thank
everybody.
you.
Take care,
Bye,
team.
everyone.
Bye now.